Start. Good afternoon. Today's class is based on anabolic steroids and drug acting on uterus. We had done a little bit of change, and we are taking anabolic steroids today instead of taking female hormones, because in the next class we can do that the female hormones and contraceptives in one go. That will be a much better thing to understand. And in this class we'll discuss about the anabolic steroids and drugs acting on uterus. So we'll divide this class into two different parts. First is the anabolic steroids part, in which we'll study about the classification, the pharmacological basis of use of anabolic steroids, and most importantly, what are the major adverse drug reaction of these anabolic steroids and where we are going to use these anabolic steroids, the medical uses of anabolic steroids. Now, this is the first class. The second class will be on, the second part of the class will be on the drugs acting on uterus. Okay, so if we say what is an anabolic steroid, what is an anabolism? Anabolism is something you want to build. The catabolism is to destroy. Anabolism is to build. So these are these steroids which are anabolic in nature, which builds, which are produced by synthetic androgens. The difference between the synthetic androgen and the androgens and the anabolic steroids is that they are basically the same. Only thing is that they have more activity on anabolism, and they have less activity on androgenicity or androgen receptors. For example, if we take testosterone as one value of it, that means it has both equal value on anabolic steroids and anabolic mechanism and androgens. Uh, the activity of these steroids is much higher, and they have much higher anabolic activity, and almost three as compared to the one of the testosterone is there, if we see in relation to anabolic steroids. So the difference between testosterone and or any androgen and these anabolic steroid is simply that they're almost similar. They have activity on androgens also, but their activity on which can increase the muscle mass, which can increase the anabolic synthesis in the human body, is much higher than the normal testosterone. So this is the major difference between the anabolic steroids and the androgens. They are mostly these steroids are mostly required for when there is a mass, you want to gather a patient is losing a lot of mass, so muscle mass. Then in that case, anabolic effects are required. You want to gain muscle mass, so in that case scenarios they are used. There are very few examples. There are very few places in which you are going to use the anabolic steroids because they inherently have the adverse drug reaction of, let's say, androgens like testosterone, and they also have adverse drug reaction of an anabolic moiety which is added to them. So therefore, they have side effects and they have to be used with caution. Okay, so if we see, there are two kinds of, one is the 17 alpha alkyl substitutes of this compound. These are oxymetholone, and then stanozole. Then there are others like methandione and nandrolone. These are all different anabolic steroids which are there. Uh, Most of them, the 7 alpha, most of them are actually used intramuscularly, either weekly or bi-weekly. These are the older ones like nandrolone. It is used weekly or bi-weekly IM injections. The newer one in which they have 17 alpha alkyl group, and when this 17 alpha alkyl group is is added, they can be used as oral as well. So there is a stanozol which is given orally. So we have both compounds which can be given orally or which can be given IM. So these compounds can be they are used in these conditions, different conditions. So how does this anabolic steroids actually act? So anabolic steroids are basically the androgens. As I told you earlier, they are not different from any androgen, but only the difference that they have from androgen is their activity, more activity for the anabolism. So therefore, their action is almost similar to the to any androgen. So if you take from your general pharmacology classes, if you take this as an androgen and this is your an anabolic steroid or an androgen steroid, and it has to go inside the cell. The receptor for these steroid receptors are intercellular receptors, so it has to go inside the cell. The androgen receptors usually are there in the cytoplasm. You know the cytoplasm is a very chaotic place. It can be degraded very easily. These receptors are just proteins, and therefore to protect themselves from the degrading enzymes, it has been um protected by a protein called as HSP or heat shock protein. Now, what happens is that these androgen it goes into the cell and it replaces this HSP. So there is a drug receptor interaction which is happening in the with the androgen and androgen receptor. Mind you, most of the time that you have studied the G protein coupled receptor and other receptors, they are on the surface of the cells, while these receptors these are in the cell, intercellular receptors. Now these receptors then get dimerized, and this whole receptor ligand complex then moves into the that your nucleus. In the nucleus, it migrates to a DNA, the part at which it wants to um, act, and this part, that part which on which it will go and attach, that part will be used. That part will cause transcription of certain elements of that of the androgen. These are called as androgen response element. It can increase the synthesis of some protein, transcriptome, or it can decrease the synthesis of some protein. And finally, it can modulate. Basically, it can increase also, it can decrease also. It will modulate the response. This is the androgen response element. And finally, when there is an androgen response element is activated, there is synthesis of some proteins which increase or decrease the functionality of that cell with respect to the steroids. Now, this is basically what we call as the mechanism of action of this anabolic steroids. Now, what are the major uses of an anabolic steroid? As I told you earlier, the most important use in this of these anabolic steroids is basically to increase the muscle mass. And if you can think uh, in which states there is a decrease in muscle mass, the one thing that pops out very quickly is that cancer chemotherapy. Whenever a patient, if you've seen a patient in your relation or in your friend circle or during your ward posting, any cancer patient, you have seen that the cancer patient has lost a lot of weight, and in those conditions, there is a catabolic state going on. It can be due to the cancer itself, or it can be due to the chemotherapy or the drugs which are highly toxic drugs of cancer, which are given to this patient. Now, in these patients, we can give an anabolic steroids. So it can be given in cancer chemotherapy induced cachexia. Cachexia means loss of weight or decreased appetite, and it's a combination of the symptoms where the muscle wasting, the loss of weight, decreased appetite, everything is present. So cancer chemotherapy induced cachexia is one of the um, major use of this indication of this anabolic steroids. Apart from that, acute illnesses, major surgeries can also lead to, especially the GI surgeries in which a large part of the bowel is being eliminated or removed. In those conditions also, this catabolic states sets in, and then we can use these anabolic steroids. It usually helps a lot in these kind of scenarios. So they act by reducing the nitrogen loss. Basically, we know that the proteins are built on the building block of proteins is the different amino acids, and these amino acids are basically made up of one of the major component of these amino acids is nitrogen. So it reduces the nitrogen loss, it increases the muscle building activity, and therefore the nitrogen loss is decreased. Then there is slight problem, and we'll discuss this in the adverse drug reactions, that this response, this increase in the muscle mass and decrease in the nitrogen loss, it is transient in nature. That means it can only work for a shorter period of time. On long-standing process, it might not be very effective. So therefore, in short chemo cycles, or in short time after surgery, or in acute illnesses, this might be a pretty good help. But in chronic conditions, it might not be it might not be a very good idea to give anabolic steroids on a longer duration because of the side effects that they have. Apart from this, they can also be given for osteoporosis, although they are not the first choice. Alendronate or zonidronate, which we'll study in the classes of calcium metabolism. These drugs are preferred usually in elderly male who are immobilized due to any fracture or any chronic illness. These on these elderly males where osteoporosis is set in, then you can actually give this in a shorter course of therapy. But you have to understand that the preferred drugs are still alendronate and zoledronate. Then in prepubertal boys, suboptimal growth. If you're seeing that there is some optimal growth, you can use it for a small time to just give a push in the growth. Secondly, they can also be useful in hypogonadism. If the patient is diagnosed with that, they might be helpful in pulse therapy. But we have other good drugs, for example, somatotropin is there, which can be used in these conditions. Then anemia of malignancy or hemolytic anemia or hyperplasia. In all these things, in all these conditions, increase in RBC count and hemoglobin can be seen after use of these anabolic steroids. Although erythropoietin is a better preferred drug in these patients. If these drugs are contraindicated, these drugs are contraindicated, then maybe anabolic steroids can be given. Although the main stray of treatment of cancer chemotherapy induced cachexia or cachexia of major surgery, you can go for anabolic steroids. It's a wonderful drugs for these conditions. Now the second part is they can also enhance the physical abilities in athletes, and maybe because of the role of these steroids in building muscles, if you take if the person is taking any steroid, anabolic steroid, and doing exercise, it actually results in the increase in muscle mass. But as I told you earlier, there are two things, that this is a very short duration. After a long duration of treatment, or you stop taking the drugs, then your muscle mass again come back to the original muscle mass. And secondly, the effects are short lived. The only the Also there is a slight difference what is mean by the increase in muscle mass and increase in the performance. So now there are a lot of studies which have shown that these improved performance is not there. Only muscle mass increase is there. The muscle functionality improvement is not there. So the athletes are basically getting good muscles, but they are not able to improve their performance in any kind of muscular activity. And of course, this is illegal to have the muscle power improvement, and all the dope tests, including the dope test of Olympics or any other sports. If you are taking anabolic steroids, it's a illegal thing, and it might lead to barring of your candidature from that sport. So. Taking anabolic steroids to enhance physical activity in athletes is actually not a good idea. Firstly, because the effects are short-lived. Secondly, because they can increase the muscle mass but may not increase the performance of that person. And thirdly, and which we'll talk about this in this slide, is that these anabolic steroids, they also cause a lot of adverse drug reactions. So the first one and the foremost is the damage to the liver, and this damage is basically presented as cholecystatic jaundice. Now the uh, the drugs, that is sulfa 17 alpha allyl groups, which made these steroids to take orally. This is the main culprit here, and it is more pronounced with those steroids in which the reason 17 alpha allyl group is there. So the IM steroids might have a different ADR profile. At least they have less chance of getting cholecystatic jaundice. Next is after the jaundice, they can also cause decrease in the HDL and increase in the LDL. And you know that HDL is a good cholesterol, and LDL is a bad cholesterol. That means it might increase the chance of cardiovascular diseases, especially atherosclerosis. So therefore, these two important adverse drug reactions are related to the liver. Then there is in females there is a problem of virilization. That is, they can be excessive body hair, menstrual irregularities are there in females. It is because of the, not just because of the anabolic effect, but it is because of the androgenic effect of the anabolic steroids. Remember, I told you that they have more propensity for anabolic effect, but they still have their effect on the androgen receptors. So therefore, in females, it might cause some virilization, and definitely they will cause salt and water retention, and leads to edema, which might be not a good thing in athletes, and therefore in athletes it's not a very good idea to take anabolic steroids. Now the next one is the contraindication. So basically the contraindications are the same contraindication for any androgen like testosterone. Anything which relies on testosterone to growth, that part or the cancer of that part will definitely grow with these anabolic steroids because they have androgenic properties. Now, for example, carcinoma of prostate, male breast, some of the liver kidney disease, and during pregnancy, these are totally contraindicated in these patients. Now, let's start our second part of the lecture. This is the drugs acting on uterus. If you have any questions regarding this, you can ask the question right now. If you have any questions, you can ask in this live chat box. Okay, if there are no questions, then we can move forward. So the next part of the lecture is the drug acting on uterus. By the end of this class, we'll try to understand what is the basic physiology of uterine contractions, and the role of posterior pituitary hormones. We'll discuss what is the contraction, what is the main drug which can cause contraction of the uterine musculature. Then we will discuss the opposite drugs, that is the drugs which can cause dilatation of the uterine musculature. And to understand this better, we'll take three cases, very easy cases, and we'll try to understand which drug to be given in these three cases, and you will then able to understand what kind of drug to be given and how to give those drugs. So the case one is a pregnant female actor with mild or irregular contraction and signs of exhaustion. She's in labor, and therefore you want to give some drug to increase the contraction, to augment the process of labor. So we'll discuss what kind of drug that we are going to use in this patient. Then in case two, we have postpartum female. That means after the baby has born, the postpartum female is there, and she has bleeding per vagina. After that, after the delivery of placenta is being removed, and now the patient is having bleeding. This is a classical case of postpartum hemorrhage, and we want to control this hemorrhage. So, what are the options we have with us, so that we can treat this patient? And the third one is the pregnant females at 32 weeks of pregnancy. The patient is having pain and contraction of the uterus. It's actually pretty early in the 32 weeks of pregnancy, and the patient is having contraction, which is not good. It might lead to abortion. So we want to somehow decrease the amount of contraction in these patients. Basically, it's the case of a preterm labor. So we'll discuss the different drugs that we have on the basis of these cases. So if you see, this is basically a pelvic diagram showing this is ovaries are there, then fallopian tube is there, then this is the uterus. If you see the uterus, there is a three important part of the uterus musculature is there. There's a large part which is a upper segment. There is a small lower segment of the uterus. Then there is a cervix of the uterus. Cervix is the opening of the uterus. So the upper part, the lower part of the uterus, and the cervix of the uterus. So the upper part is the most important part, and most of the drugs that we are going to use in labor are basically acting on this upper part of the uterus. Now, in non-pregnant uterus, the walls are very thin, and the upper part is actually very thin. You can see that the cervix is closed, and there is a very small hollow cavity which is there in the non-pregnant uterus. Now, this because the muscle cells are elongated. They are not obese cells. They are not obtuse cells. They are elongated cells. Now, what happens at the time of purturation? This fundus starts contracting. There's a start of contraction from the fundus. This is called as fundal dominance. So the upper part of the uterus, especially the topmost part of the uterus, is called as fundus, and the contraction starts from here. So when the contraction starts, the it causes retraction of these cells. These cells get retracted, and they become from the elongated cells to more obtuse cells. They become more thicker, and their size actually decreases. When this contraction takes place, what happens? There's a contraction taking place, and at this point, what actually happens is that it pulls the cells which are there, which are here in the lower segment in the cervix, upwards because of the contraction of these cells around the fundus. So when it pulls it there, what happens that the cervix and the lower segments get pulled up towards the fundus in both direction, and therefore the cervix the opening of the cervix become larger, so that the fetus can now be you know can be brought out from the birth canal. So this is basically what is happening here. So what I want to emphasize is that the elongation of the cervix and increase in the diameter of the cervix, the opening of the birth canal. This all takes place because of this fundal contractions. So these fundal contractions are very important. The upper segment contractions are very important. When they contract, they pull this upwards, the lower segment in the cervix upwards, and this part where the cervix is being pulled up and become the birth canal become larger and larger, that this part is known as the ripening of the cervix. The cervix is been ripened, and it's time for the purturation. So when we see this myometrium, if you see this myometrium which is there here, this is nothing but muscle, and this muscle basically has a lot of muscles, and a lot of blood vessels are there. Now these blood vessels are not the actual blood vessels. If you see, this is a non-pregnant female, and in which you can see a lot of tortuousness is there, and basically it goes and binds to the placenta. If the placenta is there, it will go and bind to the placenta. Now in a pregnancy, this blood vessel will go and bind to the placenta, and the part of the decidua, that is the part which is normally removed while in the menses, is menstrual cycle. This part is the decidua part is basically removed from the from this myometrium. So the thing is that this tortuous veins, these arteries and veins, which are the blood vessels which are present, uh, it allows the muscles. It is basically between the muscles. You can see that muscles are zigzag between these arteries. When the muscle contracts, this supply get impaired, and therefore the contraction is sometimes good or sometimes bad for the for a pregnancy. So it is good when there's a lot of blood loss is going on. We can contract the muscle, and therefore the arteries in which the blood is being oozed out can be contracted. Now, in other cases, if there is normal pregnancy going on, and if the if it is contracting, it might also lead to asphyxia of the fetus, or sometimes make cause premature labor, which is not required in our case. So therefore, we have to modulate. We have to modulate whether we want to cause contraction, and we want to have dilatation of that myometrium. So first, we'll start with the uterine stimulants. Sometimes they are called as oxytocics or abortifacients, but we'll call them uterine stimulants. So the first one is, and the most important one and most commonly used, is the oxytocin. It's a naturally occurring hormone, which is the posterior pituitary hormone. And the second one is ergometry. We'll see what is the difference between the oxytocin and ergometry. Then we have prostaglandins like misoprostol and galoprost, and then we have uh, some miscellaneous abortifacients like quinidine and etridine, and these are not important. The two most important one is the oxytocin and ergometry for our cases. Misoprostol and galoprost are usually used early on and they are used as abortifacients. So we'll first take the oxytocin. Oxy means fast and tocos means childbirth. So it is basically a hormone which help or which increase the time for childbirth. It does release from the posterior pituitary. If you see the oxytocin and the other hormone which is released from the posterior pituitary is vasopressin. You can see here that it's a quite very similar. Both the compounds are quite very similar. Both the hormones are very similar, apart from this small NH group. And this is the main difference between them. And therefore, oxytocin possesses a lot of action of vasopressin also. Although they are not that efficacious, but they do possess the effects of each other. So what happens? The oxytocin is synthesized in the preoptic nucleus or the paraventricular nucleus of the hypothalamus. It gets stored in the posterior pituitary. You all know this from your physiological classes, and then it is released into the blood, and it goes and reaches to the to your uterus. In the uterus, they go and bind to the oxytocin receptors. Now, in the normal situation, the oxytocin receptors are not, there are not many oxytocin receptors on the uterus. They are well spaced out, and there are not many receptors are there, or oxytocin receptors are there on the uterus. But in case of pregnancy, when at the time of parturition, this oxytocin receptor, the density of the oxytocin receptor increases, especially at the site of this, which we have called as the fundus. So fundus dominance is basically because of the contraction of this fundic myometrium, and this contraction is because of the presence of oxytocin receptors. Now we have oxytocin receptors are there. The hypothalamus is releasing oxytocin, and therefore the body is now ready for parturition. Now, just to very quick look at what is actually happening at the level of the cells. Uh, this is not very important for you, but I just want to give you an overview what is happening in the cell and what is actually contraction means here. So this oxytocin receptor is a GQ receptor. The drug will go and bind to this receptor. It will cause release of phospholipase C, and it will cause the phosphoinositol 4,5-bisphosphate breaks down into two parts, DAG and IP3. The important part is here is the IP3, that is inositol triphosphate. It's water soluble, it is inside the cell. What it does, it causes release of calcium from the mitochondria. It also causes release of calcium from endoplasmic reticulum. So by the help of the IP3 receptor on these cell organelles. So these the basic thing is that As the drug binds to this GQ receptor, it will cause an increase in the IP3 receptor through phospholipase C, and this IP3 causes increase in the calcium with the help of the IP3 receptors, and this calcium, which is stored in the mitochondria and endoplasmic reticulum, it is released. So what happens then? It goes and binds to the calmodulin. The calmodulin calcium complex then causes myosin light chain kinase. There are two light chain kinases. The myosin light chain there is myosin, and there is a the three filaments are myosin. The three filaments are the actin receptor. So it causes phosphorylation of the myosin. What it does is that the actin, which are also present in the cell, it forms the bridges, and the distance between the myosin and the actin decreases, and therefore there is a contraction. This happens in each cell, therefore there is a contraction in all the cells which are showing this receptor. This is the oxytocin receptor. Wherever this is there is present, this activation of myosin takes place because of the calcium, and therefore the distance, because of the phosphorylation and bridges formed between actin and myosin filaments, the size of the cell decreases because of this infrastructural bridges which are formed between myosin and actin. Therefore, the cell contracts. The cell contracts, the whole upper fundus contracts. The whole upper fundus contracts. They will pull up the lower part of the uterus. They will also pull up the cervix. Now, when they pull up the cervix and they pull up the lower part of the uterus, what happens? They increase the size of the birth canal, and through that birth canal, when there is an upper pressure from the upper side of the contraction because of the upper fundal contraction and large birth size, the fetus gets pushed down from the uterus, and this process is basically called as parturition or childbirth. Now, what is the basic effects of this on uterus? It will cause increase in the force and frequency of the contraction. So the very important thing here is that the oxytocin causes increased frequency of contraction. Increased force of contraction, all the drugs causes. It also causes increased frequency of contraction. That means there are a gap between each contraction. It's not like that key, it's totally contracted. There's a gap between each contraction, and this is very important because this gap, as I told you earlier, that the blood vessels which are in the myometrium, they are when the myometrium is relaxed, they can supply blood to the fetus. This is very important. Otherwise, the fetus will become asphyxiated. That means the oxygen supply to the fetus is deranged. So this gap is required. We want to increase the frequency of contraction. That is good. We do want, but we want not a sustained contraction, but we want a contraction with frequencies. That means in between there are gaps of relaxation also. This is very important. I'll tell you why this is important as compared to other drugs. Now, as I told you earlier, the non-pregnant and the early pregnancy uterus is basically resistant. Why it is resistant? Because there is less amount of oxytocin receptors. Then, uterus at term and during parturition is highly sensitive because there are a lot of oxytocin receptor. In which part is most contraction taking place is the upper part of the uterus, on which the a lot of contractions are taking place, and which is the basic driving cycle of this whole parturition cycle. Okay, and of course, as I told you earlier, there are relaxation in between the contractions. Now, if we see the oxytocin, usually we give oxytocin by IV route. Whenever if you are posted in the gynecological OPD, IPDs or in the labor wards, then you will see that almost in a lot of patients, IV oxytocin is given basically it is given in an infusion, and we'll see why it is given in infusion. Do you have any idea why do you want to give as an infusion and not in just an IV bolus? Think about it, and we'll discuss it. So this oxytocin is metabolized by liver and kidney. Therefore, if the patient is having damage in liver and kidney, we have to be very careful about it. The half-life is only 4 to 12 minutes. Now you can see why we want to give it IV infusion, because the half-life is very small. You can't just give him injections one after the other. We have to give it by IV infusion because of the very small half-life. Then it can also cause milk ejection reflex because of the contraction of the myoepithelial around the mammary alveoli. Then we have already said that it is like an vasopressin like action. So water retention can happen. If the water retention is more, like you are infusing IV fluid, a lot of IV fluid with the oxytocin, it might cause a lot of water retention, which may lead to water intoxication, which is basically hyponatremia, dilution hyponatremia, and edema all over the body. This can happen. So whenever you are going for oxytocin infusion, you have to be very careful about this water retention also. Then in CVS, it can cause vasodilation. Then there's some CNS effects also, which are not very important. The main thing is that the T half is only 4 to 12 minutes. Therefore, it is given as IV infusion, not as an IV bolus. It may be given as IM or nasal spray. Preparations are available, but still IV infusion is the mainstay of treatment here. Then water intoxication, because I've shown you the vasopressin have a very similar structure. So this the oxytocin can also have the ADH like effect, vasopressin like effect, and may cause water intoxication. This is one of the more important adverse drug reaction. Now the uses in oxytocin in human beings, basically it is used for induction of labor. If the labor is not induced, you want to induce the labor, then you want to give 5 impressional units of oxytocin, which is mixed in 500 ml of normal saline, and which is titrated accordingly and given to the patient. Usually the labor starts within hours. In case of uterine inertia, that means the labor is not progressing satisfactorily. It is induced. The contractions are there, but the contractions are very weak. In that case, also you can give oxytocin. Postpartum hemorrhage, it can be given by an IM injection. See, in all the other cases, in labor and in uterine inertia, you are giving as an IV infusion. In postpartum patients, it can be given as IM injection. And I will tell you why it's not a very good choice for an IM injection for an postpartum hemorrhage. It can also be given for breast enlargement if the milk ejection reflex is not there. In that case also, the oxytocin can be given. But the most important role of oxytocin is these two. The first one, the induction of labor, which is given as IV infusion. Remember, IV infusion in normal saline. 500 ml normal saline, you will mix 5 international unit, or you can titrate accordingly if you want to increase or decrease the dose. And secondly, in the uterine inertia, these are the two most important uses of this oxytocin. Now there are other oxytocin preparation which are present. One is the buccal formulation, which is quite less effective. This is desamino oxytocin, and there is one more carbetotoxin, which is also there, which is a longer acting analog of oxytocin, which decreases the amount of that decreases the necessity of the IV infusion. So these are there, but still oxytocin is mainstay. IV infusion of oxytocin is the mainstay of treatment. Now let's come on to our second most important drug. This is the ergot alkaloid. Basically, it is from the fungus Clamster purpura, and it acts on the 5-HT2 receptor. It's an agonist on 5-HT2 receptor. Basically, it causes increase in the force of frequency and duration of contraction. That is good. It contracts all the parts of. It is not acting through the oxytocin receptors. So it acts on the 5-HT2 receptor, which are present in all the segments of the uterus. Therefore, it contracts all the part of the uterus. In moderately high doses, there is no. In the lower doses, there might be some in between relaxation is there, but in moderately high doses, the relaxation is not there. So there is a this makes it a good drug for some patients of postpartum hemorrhage, and in those patients, it is usually given in a dose of 0.2 milligram IM, and it has to be given after the delivery of anterior shoulder. If you have gynec postings, you know that anterior shoulder delivery is a very important. It's a very important milestone in the birth process. So delivery of if you give before that, you might hinder the delivery of the child. So therefore, it has to be given after the delivery of anterior shoulder. This is very important. So it because it causes contraction in all the parts of the uterus, it is a very good choice after the birth. If the patient is having bleeding, then it can be given, and it's a good choice for these patients. Now, if we see, just look at what is the difference between the oxytocin and ergometry. Oxytocin is synthetic. Of course, the ergometrin, as we said earlier, that it's derived from the Clamster purpura, which is a fungus. Oxytocin is a peptide. It's an alkaloid. Oxytocin receptors it binds to the oxytocin binds to the oxytocin receptor. Ergometrin binds to 5-HT2 receptor. It's an agonist on the 5-HT2 receptor. Action on uterus. Oxytocin causes contraction of the fundus and the body. Mainly, it contracts the fundus, while the ergometrin contracts the whole uterus. So, if you see the lower segment and the cervix is dilated while you give the oxytocin, because it pulls the lower segment and the cervix upwards towards the contracted uterus or contracted fundus. But in ergometrin, there is no relaxation. The tone is very highly increased, but there is no relaxation. Therefore, it cannot be used. The higher doses of ergometrin cannot be used for induction of labor. It should not be used. Now, oxytocin is not orally effective, while ergometrin is orally effective. It can be used. It can be given as IV or IM as compared to IV infusion of oxytocin. Half-life is quite long, that is 1 to 2 hours for ergometry, and it's quite short for oxytocin, which is around 4 to 12 minutes. Main uses, as you can see from the properties of both the drugs, the oxytocin is basically used for induction of labor. Why it is used for induction of labor? One, that it causes contraction of the fundus and body, and it causes dilatation of the lower segment on the cervix, thereby creating a very good birth canal for parturition, for childbirth. So it will push, because of the contraction of the upper fundus, will push the child or push the fetus downwards. So, and secondly, it has relaxation between contraction. So the oxygen supply to the fetus is maintained even during the process of parturition. This is why it is used in induction of labor. While ergometrin is used in postpartum hemorrhage. Why it is used in postpartum hemorrhage? It's used in postpartum hemorrhage because it contracts the whole uterus. The bleeding can occur at any point. So because the bleeding can occur at any point, So we want the whole uterus to be contracted. We don't want any relaxation in between, because in the relaxation, the bleeding will start again. So therefore, we want ergometry is a very good choice for postpartum hemorrhage, because it contracts the whole uterus, and secondly, there is no relaxation in between. Now there are other drugs like prostaglandin E2. They stimulate both the pregnant and non-pregnant uterus. Also cause cervical ripening, that is dilatation and softening of the cervix. As I told you earlier, that the main role of prostaglandin is the first trimester abortion. Mostly they are used for first trimester abortion. They can also be used for cervical priming. So the two major roles of prostaglandins are abortion and cervical priming. Apart from that, it can also be used in PPH and induction of labor, but not as a standalone agent. They can use for cervical ripening in patients in which it is not the ripening is slower while giving the oxytocin. So let's see our first case. The pregnant female at term, mild with irregular contraction and signs of exhaustion. The patient is in labor. What drug do you want to give? Think about it. What drug that you want to give in this patient? You want to induce a labor. So as we discussed, oxytocin is the drug of choice. Why? Because it contracts the upper segment, you have shorter half-life, cause relaxation between contraction, and the contraction are actually quite consistent. Now, in our second patient, there is a postpartum female with bleeding per vaginum after the delivery of placenta, and we diagnose it as a postpartum hemorrhage case. What kind of drug should we give in this patient? There is a bleeding. We don't know where the bleeding is. We know that it is from uterus. We want to contract the whole uterus. So ergometrin is the drug of choice. We want to contract the whole uterus, and we don't want any relaxation in between. After childbirth, we don't want any relaxation in between. Therefore, these two cases, we require different kind of drugs based on their properties. Oxytocin is given by IV infusion. Ergometrin is given by usually IM after 2 mg IM um, after the delivery of the entire shoulder of the child. Now let's take on the third case. We have a pregnant female at 32 weeks of pregnancy. Pain and contraction of the uterus is happening, and therefore you know that the patient is now in the preterm labor. You want to delay this labor at least till 36 weeks of pregnancy. What do you want to give to this patient? You want to decrease the contraction, and you want to decrease the uh, contraction, and you want to decrease you don't want that these contractions may lead to cervical ripening or formation of a birth canal or dilation of the cervix. You don't want that. So what kind of drug that you want to give is basically the opposite of these two cases. So these are called as tocolytics. Tocolytics are basically uterine relaxants. We have 3 or 4 kinds of tocolytics. First is the oxytocin receptor antagonist. There is atoxaban, then calcium channel blocker, which is again before atoxaban, it was one of the most commonly used drug, nifedipine. Then prostaglandin synthesis inhibitors like indomethacin can be used. Beta agonist like ritrodrine here is also used before. Now it is not very used, but very commonly used. Nifedipine and atoxaban is one of the drugs which are more commonly used. There are some miscellaneous drugs like magnesium sulfate. If the patient is having eclampsia also, then magnesium sulfate might be very good choice. Eclampsia is the patient is having a high BP in pregnancy, induced hypertension is, and some seizures also. So that in that cases, magnesium sulfate can be given. Nitroglycerin is also a good choice because it increases the cyclic GMP, and it can which can dilate the uterine muscles. So these are the drugs which can be given. Let's our basic aim in this is to, as you can see, the calcium causes myometrial contraction. Any contraction in anywhere in the body, calcium causes that contraction. So if you want to decrease the contraction, then you want to use then you want to decrease the calcium. And all our drugs, they are basically causing decrease in this calcium concentration in the myometrial cell. Atoxic causes this by inhibiting the oxytocin receptor. We know that it's a GQ receptor. GQ receptor, we know that it increases the calcium. We have seen that it increases the calcium because of the IP3, which is formed in the cell and causes release of calcium from mitochondria and endoplasmic reticulum. Therefore, it decreases the calcium. Then we have calcium channel blockers. As the name suggests, they will block the L-type calcium channels, and therefore they also decreases the calcium in the biometric. Then we have COX inhibitors. COX inhibitors are basically nothing but the prostaglandin inhibitor. We know that prostaglandin can cause contraction. Therefore, they act through GQ receptor, or they can also act through cyclic AMP. So while we inhibit the COX inhibitors like indomethacin or diclofenac, they inhibit these PGE2, PGF2 alpha, and thereby decreasing the calcium level in the myometrium. Then magnesium sulfate also cause a decrease in the calcium uptake through blocking the L-type calcium channel. All this lower amount of calcium cause myosin light chain kinase to not phosphorylate that much, and therefore the contraction are decreased. The myosin light chain kinase can also be inhibited directly by increasing the cyclic AMP, which can also cause decrease in the phosphorylation of the myosin light chain kinase. So the actin and myosin bridges are not formed, which ultimately lead to contraction. And this phosphorylation is also inhibited by increase in the cyclic AMP levels. So beta 2 agonist causes increase in cyclic AMP levels, and therefore the contraction is decreased. Okay, so we take only one or two drugs. Atoxic Bond here is given in the injectable form. It is approved in India in 2015. It's quite new drug. It actually given in the preterm birth in pregnant females who are with three conditions, that they have regular uterine contraction of at least 30-second duration at a rate of more than 4 per 30 minutes. If that is there, you can give this to the Atoxic Bond to the patient. Or there is cervical dilation of 1 to 3 centimeters, an effacement of 15. Let's not talk about the effacement. The cervical dilation of 1 to 3 centimeters, and the gestational age of at least 24 to 33 weeks with a normal fetal heart rate. Then in those patients, in those pregnant females, this Atoxic Bond can be given. So to summarize, I hope you understand this topic. To summarize this, the oxytocin is basically causes contraction of the upper segment of the uterus, and therefore it is used for induction of labor. That's it. इतना अगर समझ में आ गया is more than enough, and then you can build on it. That oxytocin is used for induction of labor. Why? Because it can cause contraction of the upper segment of the uterus, and which is why the fetus is pushed downwards. Also, because of the contraction, the lower segment and the cervix is pulled upwards. Therefore, the cervix dilates and the whole birth canal is formed. This is one thing. Second thing, agometrine. Agometrine is used for the can cause contraction of the whole uterus without any relaxation. The higher, moderately high doses can cause this. This is good for postpartum hemorrhage because we want, after the childbirth has taken place, after the placenta has been thrown out, what we want is that the patient, our mother, should not have any bleeding. It's a very important cause of postpartum deaths in our part of the world, and therefore augmentin is a very important drug to use in this patient. It is usually given after the anterior shoulder of the baby has been delivered. After the anterior shoulder has been delivered, you can give through the IM route. Oxytocin was given by IV infusion. Ivermectin is given by IM route after the delivery of anterior shoulder um, of the fetus. Then, in preterm labor, you want to delay the preterm to at least 34 to 36 weeks. In that case, usually the calcium channel blockers, because of the availability and the lower cost, they can be used like nifedipine, or the newer drug like Atoxic Bond can be used in these patients. So we have three important diseases and three important drug categories. I hope you understand this. Any questions, please write in that live chat. If you have no questions, then thank you very much. We'll meet maybe on Friday, yeah, at uh, 10, 10 a.m. I think, and we'll discuss it further, the hormonal contraceptives, and we'll also discuss the hormones, female hormones. It will be a very important topic and a very very practical topic for you. And I really want you to come prepared. Read a little about the female hormones, and then we'll discuss and we'll build on it. Okay, no questions. Then thank you. We'll end the stream.